Hello, everyone. Thank you very much for attending our lecture on the sacroiliac joint. My name is Matt Callison. I'm here with my colleague, Brian Lau.
Hi, nice to be
Thank
here
you very much.
again.
Thank you very much to the American Acupuncture Council for having us. Brian and I were talking about the upcoming Module 2, Low Back, Hip, and Groin for the Sports Medicine Acupuncture Certification Program that's in September. We were thinking about different ideas of what we could be able to present today. And because sacroiliac joint pain that would be presented in September and November is so prevalent with many people with different lifestyles that we thought it'd be a good idea to share with you some of our experiences of different points and different things that we could be able to use for releasing sacroiliac joint pain and dysfunction. What we're doing is actually just going to be providing you in this short period of time just a slice of the pie of things that can be used to help to reduce pain in the sacroiliac joint. There is quite a few more things that you'd have to take a look at, but that would end up taking quite a few days to be able to go through all of that. So let's go ahead and get into these pearls, these nuggets, these wonderful protocols to be able to use for sacroiliac joint pain and dysfunction. So the next slide there, if we could go to, is it's such a crazy common injury for people, and it can be able to come and go. It can actually really be recalcitrant for a number of different people as well, is sacroiliac joint pain. And the sacroiliac joint, the tissue surrounding that, is usually the innocent bystander from the different postural and muscle imbalances that are causing a torque or torsion, a strain within the posterior sacroiliac ligaments and also the multifidi that are just over that sacroiliac joint. So the sacroiliac joint does have a very small amount of motion, but again, it's the innocent bystander from different pelvic imbalances and muscle imbalances. And with those muscle imbalances come channel imbalances, and with that then comes channel imbalances within the associated channels. So this is something for us to be able to take a look at as an acupuncturist. Let's go ahead and present some real gems here that we can be able to instantly take pain away from the sacroiliac joint and not just needling local. So the next slide, please. This is a bit of an overview. So we could use the innervations of L4, L5 at the Wato-Jiaji points, as well as UB31 and 32. UB33 would also be a choice. It's just easier to find UB31 and 32 Ba-Liao points. So this would be where we could actually affect the innervation. We'll also talk about points along the internal pathway of the gallbladder that can be used as its own separate treatment protocol as well. And of course, local needling in the sacroiliac joint region. And the reason why I say not into the sacroiliac joint is because it's very difficult to get an acupuncture needle into that small little crevice of the sacroiliac joint. And it's something that I think as professionals, we should never say to anyone that we're actually needling into that joint. We would actually need some kind of digital imaging in order to guide us to go in there. So it's just important that we have our language straight, especially if we're going to be discussing to medical doctors or chiropractors or physical therapists. We're stimulating the tissue around the sacroiliac joint, helping to decrease pain. Then after that, we'll get into some important motor points and also some tissues like the sacrotuberous ligament that are associated with the urinary bladder and kidney Jing-Jin. So let's go ahead and start right off. I think the next slide, please. This is a repeat. These are some points that you can use. Consider when you are needling locally underneath that PSIS for the sacroiliac joint pain is the innervation site to that joint. So Wato-Jiaji points of L4, L5, needle those bilaterally as usually for the best effect for needling those points. Also UB31 and 32, I don't really needle those bilaterally, but you could. Normally, I would be needling just the side of the affected SI joint, so UB31 and 32. Good combinations with local needling. Now you can use that in addition to, let's go to the next slide. A point combination here of gallbladder 29, which is the motor point or the superior motor point for the tensor fasciae lata. You could also use gallbladder 30, or I prefer the piriformis motor entry point. I'll discuss why in just a second. That would be with your SIJ needle technique, and then also do one. So why are we using this point combination? Well, let's take a look at the internal pathway. So that image on the right, this is from Royston Lowe's book of secondary or ordinary, I think it's called secondary channels, printed in the 1980s. You can see from gallbladder 29, Brian, I don't know if you have a cursor, if you could be able to point that out. So gallbladder 29 on the hip there, we can see from that primary branch, 29 would then go to gallbladder 30. That's going to be, as we know, into the buttock region. There's an internal pathway that goes from gallbladder 29 down deep across the PSIS and communicates seemingly with the sacroiliac joint and its tissues, because the next points that it communicates with is UB31, 32, 33, and 34, the Bailey-Al points. Then that internal pathway goes down to do1, which is really quite interesting when we look at the pelvic floor. We'll have a quick discussion on that one, just a very quick. From that do1, then the internal pathway arises and goes back up to the surface at gallbladder 30. So this is the reason why we could use gallbladder 29, where the internal pathway begins before it goes to the sacroiliac joint. We could also use do1, would be a good choice because of the anacoccygeal ligament. That anacoccygeal ligament is the seam of the left and right pelvic floor, so it has a lot of communication within that region. We could also use gallbladder 30 there because that's where the internal pathway comes up and arises at gallbladder 30. Personally, I prefer to use the piriformis motor entry point in this case. The reason why is because of its influence within that region. It has a really strong stabilizing effect for the sacrum itself. When I'm using gallbladder 30, I'm actually thinking about trying to stimulate that sciatic nerve when there is true sciatica. So I'm using that for a little different purpose. Or also with using gallbladder 30, just on a side note, it's an excellent point for tonifying chi and blood, something to be able to moxa. You can use that with stomach 36. So back to the sacroiliac joint pain, gallbladder 29, where the internal pathway exits from. Gallbladder 30 is where it comes from the deep after going to the Bailey-Al points and the sacroiliac joint region in do1, resurfaces at gallbladder 30, so you could use that point or the piriformis motor entry point. That's a nice combination, and you would tie in those needles, those local needles around that area, with gallbladder 41 and Sanjiao 5 being the master and confluent points for the Dai Mai Yang Wei. Has a strong effect on the sacroiliac joint that we demonstrate quite a bit with Gillette's test in the SMAC program. All right, so that's a standalone. However, you could use that with the L4 and L5 Wato Jiaji points, or UB1 and UB30, UB31, UB32 to help tie in that internal pathway and also the innervation. It's a solid treatment. So let's go into, I think the next one, Brian's going to take over and start talking about the urinary bladder and kidney jingjin.
Yeah, so this would just be something to consider and add into the treatment. If we just kind of get an overview of the urinary bladder and kidney sinew channels, Jingjin translation for the sinew channels, we have a partial list on the left for the urinary bladder sinew channel and a partial list on the right for the kidney sinew channel. I say partial because it's only taking us up to the lumbar spine. These channels would continue higher up. But just glancing at that image, we can notice a couple things. First of all, the urinary bladder sinew channel is going to go posterior region through the glute max, hamstring tendons. We'll talk about a couple other structures, but they're going to form and unite at the posterior part of the sacrum with the posterior sacroiliac ligaments. So that's something right there. So it's going to have influence on the sacroiliac joint through the posterior sacroiliac ligaments. The kidney sinew channel is going to dive deeper anterior to the sacrum to form the ligaments on the anterior portion of the sacroiliac joint. So those channels run fairly close to each other, running up the leg and thigh, and then diverge at the pelvis, kidney sinew channel going into the pelvic floor, anterior to the sacrum, urinary bladder posterior to the sacrum, and they're going to have quite an influence on the balance of the sacrum. So we're not going to necessarily have to treat every structure listed in here, but we'll highlight a few specific ones. And we can look right now and notice on the left, we have the sacrotuberous ligament as part of the urinary bladder sinew channel. This is the ligament that goes from the ischial tuberosity to the sacrum, a major structure that supports the sacrum. So if I'm bending forward, that's going to prevent my sacrum from basically popping out of the joint. It's a very supportive structure. on the sacrum, the piriformis, part of the urinary bladder sinew channel. Glute max, which would be important, we're not going to talk about as much today, but we'll highlight that line from the hamstrings, especially the biceps femoris, into the sacrotuberous ligament, and influenced also by the piriformis. And then one last structure on the urinary bladder is one that would not be super obvious for a lot of people, is peroneus longus. And the peroneals in general, the peroneal group, it's very lateral. Looks like it's on the gallbladder channel. It's a lateral branch of the urinary bladder sinew channel. I'm going to put my cursor on it and run up through here. The gallbladder channel would run just anterior to this. So this is a lateral branch of the urinary bladder channel. It's going to go up to the fibular head and then link very strongly with the biceps femoris. And then up through there into the sacrotuberous ligament and the posterior sacroiliac ligaments. That's a key structure that we're going to be working on, that whole line in this, and we'll talk about that in this presentation. And then the kidney sinew channel will just isolate one structure, and that's part of the pelvic floor, which has a big influence on the sacroiliac joint, and that's the ischiococcygeus. So let's kind of move forward and look at those. So,
Hey, Brian.
Mm-hmm.
Hey, Brian. Yeah, can you go back to that slide? I just want to offer one thing. I
Sure.
remember something that you and I have taught in the past when we were talking about acupuncture as an assessment.
Mm-hmm.
So when the patient is laying prone and you can palpate underneath that PSIS and they have a certain amount of pain when you're palpating in that region, it's usually the peroneus longus. Sometimes it's the biceps femoris, but it's also the peroneus longus is a real go-to muscle to go ahead and treat that motor entry point and see if that'll decrease the SI joint pain. Usually it does by a good 50%. So remember that combination, the peroneus longus, the biceps femoris, and of course going into the sacrotuberous ligament. But the peroneus longus is one point that can really take a lot of pain away from the sacroiliac joint, which is it's wonderful to be able to do. So you can see patients have a lot of confidence you as a practitioner when you use one needle and you decrease their pain substantially. Mm-hmm. All right, thanks, Brian.
Yeah, sure. Yeah, this would functionally would really help support the SI joint during gait, because as you're walking and heel strike, those muscles would start firing and help that whole mechanism that supports and pulls down and kind of locks, maybe that's the right term, but supports, stabilizes, that's the word I was looking for, helps stabilize the sacroiliac joint, especially in running and walking type activities. So it's really tied into the balance of the sacroiliac joint.
Yeah, part of the force closure of the joint. That's awesome. That's great.
Right. So piriformis and sacrotuberous ligaments are ones that we'll look at a lot in this slide. This is a complex topic when we get into the movement of the sacroiliac joint. I'm not going to go into super detail with it because you have to, if you're interested, you can look up nutation and counter nutation. It's a long process to describe it, and it can get very bogged down in the mechanics. But simply speaking, as you're walking and running, you have one leg going forward and one leg going back, and the innominate bones follow that. There's going to be a rotation type motion in the innominate bones. You can picture the leg that's swinging back is going to influence that side. Let's say it's my right leg that's swinging back. Is going to influence that right side into an anterior tilt of the pelvis. Whereas the leg that moves forward, the forward leg, is going to influence the innominate bone on that side, if it'd be my left side in this case, is going to go into a posterior tilt. And then as the gait changes and the legs switch, that's going to go back the other way. There's going to be this kind of rotational type aspect through the innominate bones that's going back and forth. And even just from the get-go, you'll notice with people that there's going to be asymmetries in that. And maybe one side it goes really easily and the other side not so well. So that's going to set up the potential for things like sacroiliac joint pain. The sacrum has a particular movement in that rotation that is helped and supported by the guy wires of the piriformis and sacrotuberous ligament. That's going to prevent the sacrum from just being locked to that innominate bone movement, and it's going to create this nutation and counter nutation motion, this kind of swaying and nodding of the sacrum, and that's what kind of creates the sacroiliac joint movement. It's a very small movement, but it's an important movement. So they're there to help support and guide the sacrum and its movement within that rotary movement of walking and running. So it's very important in the balance and stability and movement of the sacroiliac joint. So because these are such key structures that are sort of holding on to the sacrum and supporting the sacrum and guiding the sacrum, it makes sense to make those part of the treatment. So piriformis, treating via the piriformis motor entry point and the sacrotuberous ligament are very key structures that you can just include in treatment for sacroiliac joint pain, but there's certain ways you can use assessment to help determine when they're going to be most effective. Manual muscle test, postural findings. There's a test for the sacrotuberous ligament that we use that we help feel for when it's overbound and preventing and locking the movement. So those can help guide it, but they're really key structures for this whole dynamic.
Mm-hmm. Mm-hmm.
Right. So let's talk about piriformis motor point. So this is from Matt's book, the motor point. You actually have in both the sports medicine acupuncture book, but also the motor point index for the location. The point is halfway between UB53 and UB54. That's how it's described in the motor point index, but easier to teach when we're teaching this motor point for location is to find the PSIS. Let me get the cursor there. Find the borders of the PSIS, lower border, upper border, medial, lateral, get right in the middle of the PSIS. That's going to be one of your points. Next point is going to be, where'd my cursor go? There we go. It's a little hard to move on this. Do 2, we know where do 2 is. And draw a line between that middle
Hey, Brian,
point. Yeah.
do we have a video for this next? It might be easier just to watch that video because the cursor is having a hard time.
Okay. Yeah, we can do that. Yeah, it's hard to control the cursor because it's kind of a small window. So
yeah, and it describes it in the video. So let's just go for that.
Okay, will do.
So I think it's the next slide. Yeah.
Mm-hmm.
Here we're looking at the lateral side of the hip. We're going to identify the piriformis and the motor entry point. So first, let's go ahead and feel for do 2, and then also for the PSIS. I'm going to take 3 fingers. I feel for that PSIS, superior border, inferior border, medial border, lateral border. And I just feel right for the middle of that PSIS. I feel do 2. From the middle of the PSIS to do 2, we're going to divide that in half. So there's a line drawn from the middle of the PSIS to do 2 being the hiatus of the sacrum. Divide that in half on that line. Okay, so then now, this point, the halfway point, you're now going to go perpendicular to the line until you feel the edge of the sacrum. From the edge of the sacrum, we're now going to follow that line, just continue one more sun. Identifying the PSIS, inferior border, 3 fingers, medial border, superior border, and lateral border. Go right into the middle. Take the other hand to the sacrococcygeal junction, which would be due to the hiatus of the sacrum. From the PSIS to the hiatus of the sacrum, divide that in half. There's going to be a line here, so divide that in half. From that line, now draw a perpendicular line, palpate out till you feel the edge of the sacrum. From the edge of the sacrum, just one more sun out, and you'll then locate the piriformis motor point, approximately 1 sun away from the lateral border of the sacrum. From this sun mark,
we can go ahead and turn that off a bit. Next slide. All right, so you guys, the continuation of that video actually does show the needle going in, but it's a perpendicular needle with a 3-inch needle going into the depth about 2 inches or so. For those people that have studied with us before, you know that this is also the piriformis motor point is an empirical motor point that softens the urinary bladder 10 region. So it's really quite useful with cervicogenic headaches. When needling for sacroiliac joint pain and dysfunction, it's always a good idea to needle bilaterally the piriformis. When you're using manual muscle testing, it's very common to have one piriformis going to be weak and then the other one would actually be strong or in a locked short position. So it's always a good idea to be able to needle both piriformis. Brian, do you want to just keep going on the sacrotuberous ligament, or do you want to take over?
You can go ahead, jump in.
All right, so in combination, as Brian was talking about earlier, is the guy wires for the sacrum would be your sacrotuberous ligament and also bilateral piriformis, the piriformis we just covered. Now with the sacrotuberous ligament, it's a very prominent, dense tissue, easy to find just off of due 2. So if you divided due 2 and the ischial tuberosity in half and did a cross fiber, so you're cross fibering where that ligament is, it's a very prominent ligament. It's about the size of your pinky. Very dense. However, it does have some flexibility. So when you find some ossuure points within that region, you can see the red arrow that's on the left is going perpendicular with the sacrotuberous ligament. That's how you want to palpate it. That's how you want to needle it. Usually in the middle section is where you're going to find some ossuure points. Using an 1.5-inch needle, you might need a 3-inch needle depending on the size of the person's bum. But 1.5-inch needle or 2-inch needle will usually go right into that area. Needling that bilaterally is usually a good idea with sacroiliac joint pain as well. Now there's going to be another muscle, the next slide. Part of the pelvic floor being the ischiococcygeus muscle. The ischiococcygeus, Brian, let's see if we can get the cursor. I know it's really challenging to do that on that right-hand side. That ischiococcygeus is going to be located under the sacrotuberous ligament. So you can see the cutaway on the right-hand side of the image. And the cutaways, you can see the sacrotuberous ligament and also the sacrospinous ligament. And where the pointer is right now is the underlying ischiococcygeus, part of that pelvic floor. So the same way that you would needle the sacrotuberous ligament, going right into that dense ligament, if you took a 3-inch needle and threaded that up underneath the sacrotuberous ligament, scraping basically the underside of it, the needle would probably be brushing against the sacrospinous ligament as well. The next tissue is going to be the ischiococcygeus. This is a game changer for sacroiliac joint pain. There's a number of different reasons why we're needling this muscle as well for lower jowl complaints. But for right now, let's just keep on the sacroiliac joint. You can consider the ischiococcygeus as part of the pelvic floor and also guy wires to help to stabilize the sacrum. So needling the ischiococcygeus is very, very safe. However, you can see that caution is advised on the left-hand side there. This technique really should be needled by experienced practitioners with excellent knowledge of anatomy. You need to have really good command of your needle technique and know where the point of the needle is going at all times with this. So if you did inadvertently go too far internal, you could affect internal organs, and that would not be a good idea whatsoever because of the risk of infection, right? So this is a wonderful point to be able to use for just for experienced practitioners only. All right, what do we have next there? We've got now the local needling, right? So the local needling for the sacroiliac joint pain, the sacroiliac joint region has been around for decades. There's different ways of going about needling it. The way that we teach it in the SMAC program is to get the upper 2/3 of that sacroiliac joint, where the pain is, and divide that into 4 quarters. From that PSIS, the medial border, you move out just medial, just about 1 cun, maybe 3/4 of a cun, in order to take a finger to press underneath the PSIS, which is the roof of the sacroiliac joint. So that finger is going to go just underneath that PSIS toward the sacroiliac joint, and you'll divide that into 4 different vectors or 4 different angles. It's always good to ask the patient, does vector A, how does that feel? Vector B, as you move down a little bit, how does that feel? Vector C, as you move down just a little bit more, how does that feel? And of course, vector D. And they'll tell you. It's either going to be, what's common is usually A and C, could be B and D. So whatever those are, you go ahead and take your 1.5-inch needle and start threading that underneath the PSIS in the direction of the sacroiliac joint. It's a great local needle technique to be able to use in combination with the other points that we have used, or at least some selection of different points that we have talked about. So great to be able to combine these needle techniques after all the needles have been pulled out with the following myofascial release technique. This is something that we teach in our sinew channel myofascial techniques class. This is also another game changer to help to reduce the tension within the tissues of the sacroiliac joint and also the glute maximus. Brian, do you want to take it away?
Yeah, we have a video for this one. So it's a pretty simple technique. I'll let the video show it, but it's working on the boundaries, the borders, and attachment sites at the sacrum. It's an easy technique just to loosen that lateral border of the sacrum and help free the sacroiliac joint. And you can modify it based on somebody in a posterior tilt or an anterior tilt. So, you can basically bring the leg up, and you'll see this in the video, in kind of like a crawl position to help bring that more anterior tilted pelvis into a posterior tilt and influence it out of that position pretty well. Or you can move in the other direction for somebody in a posterior tilt to influence and take it more into an anterior position. We'll see that in the video coming up. There we go. So we'll be working on the attachments of the glute maximus, especially the sacral attachments, and just spreading and moving, kind of softening the attachments along the sacrum. Very nice technique. We can adapt the technique to somebody who has a posterior or an anterior tilt. This model, we have an anterior tilt, but I'm going to exaggerate the anterior tilt. You can imagine with that it's going to be much more effective if I move that tissue away from the sacrum, yes, but also downward to help encourage more posteriority to the pelvis. Conversely, if somebody has posterior tilt, tuck your pelvis under, yeah. And in that case, if you were working in that same direction, it's going to encourage them more into a posterior tilt than they already are. So it would make more sense to come from a different angle and help lift the tissue to help encourage more anteriority to the pelvis. So we can adapt that general direction, but in both cases, you're moving the tissue away from the sacrum, either away and down, lateral and down, or lateral and up. So we'll start with lateral and downward. I'm going to sit a little bit at the edge of the table. My side is towards her, so I can gently let my body sink into the tissue. Using the elbow, also a little bit of the proximal ulna. I'm going to go right to the sacral attachments. Sink perpendicular, and then spread slightly lateral just to distract the tissue away from the sacrum. And inferior, I might have the patient gently and slowly tuck the pelvis under. Just a small movement's adequate. And relax. Move slightly downward. Get another area of the tissue. Sink in, tuck under. Move. That movement that you're doing is going to help them tuck the pelvis under. Relax. In, slowly, gently tuck under. We'll do one more pass. And tuck under. So in some instances, you might, especially with an anterior tilt, you might add to the technique by putting the patient into sort of a crawl position. And you can see in this position, that's going to encourage even more of a posterior tilt of the pelvis. So I can do similar technique here. Similar technique with them in this position, and the position itself is going to encourage more of a posterior tilt. And I might hold a little longer in this particular position. All right. So we have a QR code here for the new program that just started. The sports medicine acupuncture certification has been going on. This is, geez, what cycle is this, Matt, now? 10th, 11th?
13, 14.
Yeah. But this is a updated version of it where we've added significantly to the program. So for more information, you can access the QR code. The class has just started. I just actually returned from San Diego 2 days ago. So I'm still on California time, but that was not for this, but the class just started this past month for module 1. Module 2 will be in September. You can start at any time.
Low back, hip, and pelvis. It's a really popular
Yeah.
one. It's great. Yeah, it's
So definitely
starting in
covering
September.
Sacroiliac joint. And Matt, why don't you talk about this?
Sure. Yes. So we are crazy enough to be able to put on a symposium because the field needs it. So AcuSport Education, we've gotten together. We've decided that the field really needs to be able to have sports orthopedic acupuncture type of symposium. So it's something that should be happening hopefully every single year. We've got a great speakers. This is going to be coming up in March 30th to April 1st in 2023 here in San Diego. If you want any information there, just go to soaseducation.com. SOAS is the acronym for the title of the symposium. Pacific Sports and Orthopedic Acupuncture Symposium, or SOAS. So soaseducation.com. The next slide, I'm not going to get into all these introductions. You guys can go ahead and check that out. That's also going to be on soaseducation.com. The theme is going to be myofascial assessment and treatment. We've got some great people here. I can't wait for this symposium. This is going to be a lot of fun. We also have recordings through LASA OMS. That's going to be available under the online CEUs. 75% of the SMAC program is going to be online. And Brian and I are also working on an acupuncture anatomy series. You can see there on the upper left, psoas major and quadratus lumborum. And then if you want to, if you like the way our education is, then, let's get connected. We've got Facebook, we've got YouTube. Our sports acupuncture Facebook page is really quite popular. That's a great one to be able to ask some questions. You get a lot of knowledgeable people that are trying their best to be able to give their experiences with it. So, it's a good Facebook feed, that's for sure. Brian, is there anything you want to add to that?
Nope. I think we're good.
Okay.
So next week, Sam Collins will be here.
Oh, that's right. Next week, Sam's going to be here. That's awesome. Well, thank you so much to the American Acupuncture Council for having us. It's really wonderful. Brian, it's always a pleasure to be able to be hanging out with you and talking about medicine. It's great. Thanks very much. So then we'll see you next time. Thanks, everybody.
All right. Bye-bye.